You're standing in your kitchen and you can't remember why you walked in there. You call someone and the name that comes out is the wrong one. You read the same paragraph 3 times and nothing sticks. And you tell yourself, this is what getting older looks like. But what if it isn't? What if the reason your mind feels slower, foggier, less sharp than it used to be has nothing to do with how many birthdays you've had, and everything to do with something you're swallowing every single day? Today, we're talking about 5 categories of medication that are scientifically linked to cognitive decline, memory disruption, and what many patients describe as a persistent mental haze. Some require a prescription. One of them you can buy off a supermarket shelf tonight. And number 3, the one I want you to pay close attention to, is taken by millions of older adults every single night, often without any awareness that it may be quietly working against the very mind they're trying to protect. Before we go any further, there is one thing I need to say clearly, and I mean it. Do not stop any prescribed medication because of this video. Not cold turkey, not without talking to your doctor first. Stopping some of these medications abruptly can be dangerous, more dangerous than the cognitive side effects we're about to discuss. What this video is meant to give you is a list, a starting point for a conversation, a set of questions to bring to your next appointment that may lead to a safer, better tolerated alternative. Your mind is worth that conversation. Let's start it. To understand why these medications affect cognition, you need to understand a single word: anticholinergic. Your brain uses a chemical messenger called acetylcholine for 2 of its most essential functions: learning and memory. When you form a new memory, when you recall someone's name, when you follow a conversation and retain what was said 5 minutes ago, acetylcholine is central to all of it. Think of it as the neurotransmitter that keeps the memory system online. Anticholinergic drugs work by blocking acetylcholine receptors. That blocking action is often intentional and useful for the condition being treated. But in older adults, the brain's cholinergic system is already operating with less reserve than it did at 40. Older brains produce less acetylcholine, have fewer acetylcholine receptors, and have a blood-brain barrier that is more permeable, meaning drugs get in more easily and stay longer. Introducing a substance that further suppresses this already strained system can produce effects that range from temporary grogginess to, according to a growing body of research, potentially long-term cognitive consequences. A landmark study published in JAMA Internal Medicine followed nearly 60,000 patients diagnosed with dementia and over 225,000 matched controls. It found statistically significant associations between dementia risk and exposure to several classes of anticholinergic drugs, including bladder antimuscarinics and antidepressants with anticholinergic properties, after adjusting for confounding variables. A separate prospective cohort study from the University of Washington found that cumulative use of strong anticholinergic medications was associated with a higher risk of incident dementia, with risk increasing with total dose over time. The general view in medicine has historically been that anticholinergic-induced cognitive impairment is reversible upon discontinuation. For some patients, that appears to be true. For others, the research suggests the picture may be more complicated, particularly with long-term, high-dose exposure. The key phrase in both cases is the same: this is worth a conversation with your physician. With that foundation in place, let's go through the 5. Medication number 1. The nighttime pain reliever you've probably never thought of as a sleeping pill. Look at any over-the-counter product with PM in its name: Tylenol PM, Advil PM, Aleve PM, Zizquil, Unisom. The active ingredient responsible for the sleep effect in nearly all of these products is the same compound, diphenhydramine. It's a first-generation antihistamine that was developed decades ago, became available over the counter, and has remained in hundreds of formulations ever since. Largely because it was grandfathered into the market before modern clinical trial requirements existed. Here is the pharmacological reality for people over 65. Diphenhydramine stays in your body significantly longer as you age. Research has found that the half-life of diphenhydramine, the time it takes for your body to eliminate half the drug, is roughly 50% longer in older adults compared to younger ones. Depending on the individual, the drug may still be circulating in the system well into the following morning. That means you may have taken it to sleep at 10 p.m. and still have clinically significant levels affecting your brain at 8 a.m. The American Geriatric Society has explicitly listed diphenhydramine as a potentially inappropriate medication for adults over 65. Their Beers criteria, the gold standard reference for medication safety in older adults, recommends that individuals in this age group avoid diphenhydramine and similar compounds, noting the risk of sedation, compromised cognitive function, and increased fall risk. A study published in JAMA Internal Medicine found that diphenhydramine use in hospitalized older patients was associated with a significantly increased risk of cognitive decline symptoms, including inattention, disorganized speech, and altered consciousness, with a dose-response relationship, meaning the more that was given, the worse the outcomes. The reason this matters so much is the invisibility of the harm. You take it to sleep, you wake up feeling a little foggy. You attribute that fog to getting older, you take it again the next night, and the cycle continues for months, sometimes years, with no one ever making the connection. If you are regularly using any PM formulation pain reliever or over-the-counter sleep aid, this is the first conversation to have with your doctor or pharmacist. There are non-anticholinergic alternatives for both sleep and pain management that don't carry this profile. Medication number 2, the bladder drug that crosses directly into your brain. Overactive bladder is a genuinely disruptive condition. Frequent urgency, nighttime trips to the bathroom, the constant anxiety of unpredictable urgency, it affects quality of life in real and significant ways, and it deserves effective treatment. The problem is that one of the most commonly prescribed treatments for it, and still one of the most widely used despite decades of evidence-raising concerns, is a drug called oxybutynin. Oxybutynin is a first-generation anticholinergic bladder medication. It works by relaxing the muscles of the bladder, which is the intended effect. But oxybutynin is what pharmacologists call lipophilic and low molecular weight, meaning it crosses the blood-brain barrier with ease. When it reaches the brain, it doesn't stay neatly confined to bladder-relevant receptors. It binds non-specifically to multiple types of muscarinic receptors throughout the central nervous system, including the M1 receptors that are directly implicated in learning and memory. A review published in the journal Urology found that oxybutynin still accounts for more than half of all overactive bladder medication prescriptions, despite associations with impaired memory and cognition and mounting evidence of increased dementia risk. Multiple randomized controlled trials have shown that oxybutynin is consistently associated with measurable deterioration in memory, specifically in the kind of memory most sensitive to anticholinergic effects, working memory and recall. A nested case control study found that overactive bladder anticholinergic use was associated with a 23% increased risk of dementia, with the risk increasing with cumulative dose. Oxybutynin and similar agents showed particularly strong associations. The reason this is actionable: not all bladder medications carry the same risk. Research comparing different OAB medications has found substantial differences in their ability to penetrate the blood-brain barrier. Some of the newer alternatives, including non-anticholinergic approaches such as beta-3 adrenoceptor agonists, appear to address the bladder without the same cognitive profile. The American Geriatric Society, the American Urological Association, and the Society of Urodynamics have all issued guidance recommending that clinicians use oxybutynin with particular caution in older adults, especially those with existing cognitive risk factors. If you or someone you care for is taking oxybutynin or a similar bladder medication, ask your doctor specifically, is there a non-anticholinergic alternative for my situation? That single question, asked in that language, will signal to your physician that you are aware of the research and ready for a meaningful conversation about alternatives. Medication number 3, the silent thief. This is the one I asked you to pay close attention to at the start. And the reason is not because the science is the most dramatic. It's because the overlap between the drug's effects and the early symptoms of dementia is so complete that millions of people are living with chemically induced cognitive impairment and have been told, or have told themselves, that it might be Alzheimer's. Benzodiazepines. You may know them as Valium, Ativan, Klonopin, Xanax, or their generic names, diazepam, lorazepam, clonazepam, alprazolam. They are prescribed primarily for anxiety and insomnia. They work by enhancing the effect of GABA, a calming neurotransmitter, throughout the brain. They are effective, they work quickly, and they are among the most commonly prescribed medications for older adults in the developed world, with some studies suggesting that up to 30% of people over 65 in certain countries are using them at any given time. Here is what the research shows about long-term use. A meta-analysis examining data from multiple observational studies found that long-term benzodiazepine use is associated with the accumulation of cognitive deficits across multiple domains: memory, attention, psychomotor speed, verbal reasoning, executive function. In a meta-analysis including 13 studies where the average duration of use was approximately 10 years, cognitive impairment was found in all domains examined. The relationship between benzodiazepines and dementia risk is more contested. Some studies find an association, others, including a large USC study using Medicare data, find that when you carefully control for the possibility that anxiety and sleep disorders themselves are early symptoms of dementia, the association becomes much weaker or disappears. This is a genuinely unresolved scientific question. What is not in dispute is that benzodiazepines acutely impair cognition in ways that are clearly documented, affecting memory formation, attention, and processing speed, and that these effects can persist long after the drug is discontinued. The clinical phrase for this is pseudo-dementia. A person taking a high dose of lorazepam for sleep for several years may present with symptoms: confusion, memory gaps, difficulty following conversations, word-finding problems that are clinically indistinguishable from early Alzheimer's disease. They are evaluated. Sometimes they receive a dementia diagnosis, and sometimes, not always, but sometimes, those symptoms improve significantly or resolve when the medication is carefully tapered under medical supervision. That is not a miracle. It is pharmacology. This is not an argument to stop your benzodiazepine. It is an argument to bring this information to your physician and ask, given how long I've been on this and what I'm experiencing cognitively, is there a supervised tapering plan worth discussing? Cognitive behavioral therapy for insomnia, CBTI, is now the first-line recommended treatment for chronic insomnia according to most major sleep medicine guidelines. It is more effective than medication for long-term outcomes and has no cognitive side effects whatsoever. Medication number 4, the heart drug with a shadow. Beta blockers are genuinely important medications for many cardiovascular conditions. Their role in reducing mortality after heart attacks, in controlling heart failure, in managing arrhythmias, this is well-established, clinically significant medicine that saves lives. Nothing in this section should be interpreted as an argument against beta blockers when they are clinically indicated. What the research does show is that certain beta blockers, specifically those that are lipophilic, meaning fat-soluble and able to cross the blood-brain barrier, can produce neuropsychiatric side effects in some patients, and that older adults appear to be more susceptible. Propranolol is the archetypal example. Metoprolol, at clinical doses, has a lower but non-negligible risk. Atenolol, being more water-soluble, penetrates the brain less readily and is generally associated with fewer central nervous system effects. Research published in the Journal of Neuropsychiatry and Clinical Neurosciences noted that lipophilic beta blockers in elderly patients frequently cause mild to moderate cognitive deficits, with manifestations that can resemble dementia on psychometric tests, and cited case reports in which patients showed significant cognitive improvement upon drug withdrawal and reassignment to alternative therapy. The documented side effects of lipophilic beta blockers on the central nervous system include fatigue, sleep disturbances, vivid dreams, depressed mood, and in some cases, confusion and memory impairment. These effects are dose-dependent, more common in older patients, and more likely in individuals who already have some degree of underlying cognitive vulnerability. The nuance here is critical. A 2023 study published in Brain found that blood-brain barrier permeable beta blockers were actually linked to a lower risk of Alzheimer's disease in patients with hypertension, suggesting that for some patients, some beta blockers may even be neuroprotective. The relationship between this class of drugs and cognition is not simple, and it is not uniform across all drugs in the class or all patients who take them. What this means practically: if you are on a beta blocker and have noticed increased fatigue, sleep disruption, or a foggy quality to your thinking, it is worth asking your cardiologist whether the specific drug and dose you're taking is the most appropriate choice given both your cardiac and cognitive profile. Sometimes a switch from a lipophilic to a more hydrophilic agent addresses the cognitive symptoms while maintaining the cardiovascular protection. Medication number 5. The most debated drug on this list. Statins are the most prescribed class of drugs in the United States. Millions of Americans over 60 take them daily. They are effective at lowering LDL cholesterol. They reduce cardiovascular events. The evidence for their benefit in preventing heart attacks and strokes is among the most robust in all of medicine. And yet, in 2012, the United States Food and Drug Administration did something unusual. It required that all statin medications add a warning to their labels, a mandatory label change, noting that rare post-marketing reports of cognitive impairment, including memory loss, forgetfulness, amnesia, and confusion, had been received. The FDA described these effects as generally non-serious and reversible upon statin discontinuation, with variable times to onset and symptom resolution. This is a real regulatory action that is documented on the FDA's website and printed on the label of every statin sold in the United States today. What makes statins different from the other drugs on this list is that the research picture is genuinely mixed, and in ways that are important to understand. Multiple large randomized controlled trials, including meta-analyses of over 2 million patients, have found no overall statistically significant effect of statin therapy on cognitive outcomes. Several studies even suggest a modest protective effect against dementia, possibly through statins' anti-inflammatory properties. At the same time, the FDA's adverse event reporting system received thousands of individual case reports from patients who reported cognitive symptoms, brain fog, word-finding difficulty, short-term memory disruption, that emerged after starting a statin and resolved after stopping it. In some cases, symptoms recurred when the drug was restarted. These are not fabricated reports. They represent real patient experiences that meet FDA standards for inclusion in safety surveillance data. The current scientific consensus is that statins do not cause dementia and are not broadly harmful to cognition in the general population. What is documented and acknowledged by the FDA is that a small percentage of patients, estimates range from 0.1% to 0.5%, appear to have an idiosyncratic reaction that produces reversible cognitive symptoms. The characteristics most associated with this reaction include lipophilic statins, atorvastatin and simvastatin cross the blood-brain barrier more readily than pravastatin or rosuvastatin, higher doses and individual genetic factors that affect how the drug is metabolized. What this means for you: if you are on a statin and have noticed cognitive changes since starting it or since a dose increase, this is clinically relevant information for your doctor. A trial switch to a more hydrophilic statin like pravastatin or rosuvastatin, or a temporary supervised drug holiday to assess whether your cognition improves, are both approaches that physicians have used to investigate whether a statin is a contributing factor. Do not make that decision unilaterally. The cardiovascular protection of statins is real and serious, and discontinuing them in high-risk patients carries its own risks. But the conversation is absolutely worth having. Now, what do you actually do with this information? The single most useful step you can take is to request a comprehensive medication review, either with your primary care physician or, better yet, with a clinical pharmacist who specializes in geriatric medication management. This is called a brown bag review in some practices. You bring every single medication you take, including over-the-counter products, supplements, and anything labeled PM, and you go through each one asking the same systematic questions. The first question: does this medication have significant anticholinergic properties? Your pharmacist will have access to tools like the Anticholinergic Cognitive Burden Scale or the American Geriatric Society Beers criteria, which rate medications by their anticholinergic burden. The goal isn't to eliminate necessary treatment, it's to understand the cumulative load your brain is carrying, because the effects of multiple mild anticholinergic drugs can add up to something clinically significant. The second question: is there a non-anticholinergic or lower burden alternative for this specific condition? For many of the drug classes we've discussed, alternatives exist. Newer bladder medications with lower brain penetration, beta blockers with more favorable central nervous system profiles, non-pharmacological approaches to insomnia that have strong clinical evidence behind them, hydrophilic statin options for those experiencing cognitive side effects. The third question, and this is the most important one to remember: For each of these medications I've been on for more than a year, what does my treatment look like if we reevaluate it now? Was it started for a specific reason that may no longer apply? Are there signs that it's affecting my cognition that we haven't formally connected yet? The good news, and there is genuinely good news here, is that for many people, medication-related cognitive impairment is reversible. The brain is not passive. When a chemical that was suppressing a neurotransmitter system is removed or reduced, the system can, in many cases, recover. There are documented stories of patients who had accepted a foggy mind as the new normal of their 70s, who had conversations with a pharmacist or a geriatrician, who carefully adjusted or switched a medication, and who found that months later their mind was meaningfully clearer. That is not a guarantee. Some cognitive changes are genuinely due to aging or neurodegenerative disease and will not respond to medication changes. But some are not, and you deserve to know the difference. Your mind is the most valuable thing you have, not your home, not your savings, not your schedule. Your ability to think clearly, to remember the people you love, to follow a conversation, to make your own decisions, that is what independence actually means. And if something as adjustable as a medication is standing between you and the clearest version of your own mind, that adjustment is worth every conversation it takes to make it happen. Have you noticed your thinking change after starting a new medication? Has a medication switch or review made a difference for you? Share your experience in the comments. Your story may be exactly what gives someone else the courage to ask the question they've been afraid to ask. Stay informed, stay empowered, and I'll see you in the next video.